Hello and welcome. Today we're diving deep into a specific kidney disease, oxalate nephropathy. We'll explore what it is, what causes it, and how we can manage it effectively. Oxalate nephropathy occurs when there's an excessive buildup of calcium oxalate crystals in the kidneys. This excess can stem from various causes. Dietary factors play a significant role. Consuming foods high in oxalates like spinach, rhubarb, nuts, and chocolate in large quantities can increase oxalate levels in urine. Intestinal disorders such as Crohn's disease, ulcerative colitis, or small bowel resections can lead to increased oxalate absorption from the gut. Genetic disorders like primary hyperoxaluria cause the liver to overproduce oxalate. And finally, certain medications or high doses of vitamin C, which the body can convert to oxalate, can also contribute to oxalate buildup. The pathophysiology of oxalate nephropathy revolves around the supersaturation of oxalate in the urine. When oxalate levels are too high, they combine with calcium, forming calcium oxalate crystals. These crystals then deposit within the kidney tubules and the renal interstitium, the tissue surrounding the tubules. This crystal deposition triggers an inflammatory response, causing tubular injury, fibrosis, and ultimately a decline in kidney function. The accumulation of crystals obstructs the normal flow of urine, further exacerbating the damage. Oxalate nephropathy's exact prevalence is difficult to determine, as it often goes undiagnosed. It's more common in individuals with underlying conditions that increase oxalate production or absorption, such as those with inflammatory bowel disease, bariatric surgery patients, and individuals with primary hyperoxaluria. Primary hyperoxaluria, being a rare genetic disorder, contributes to only a small percentage of oxalate nephropathy cases. Dietary oxalate intake can affect anyone, but most people with normal kidney function can excrete excess oxalate without developing nephropathy. The risk increases in people with impaired kidney function. The signs and symptoms of oxalate nephropathy vary depending on the severity of the condition. Early stages may be asymptomatic. As kidney function declines, symptoms can include flank pain, blood in the urine's hematuria, frequent urination, urinary tract infections, and signs of kidney failure such as fatigue, swelling in the legs and ankles, edema, and decreased urine output. In severe cases, oxalate nephropathy can lead to end-stage renal disease requiring dialysis or kidney transplantation. Diagnosing oxalate nephropathy involves a combination of assessments. A thorough medical history, including dietary habits and any underlying conditions, is crucial. Urine analysis is performed to measure oxalate levels and identify crystals. Blood tests evaluate kidney function by measuring creatinine and blood urea nitrogen (BUN) levels. Renal ultrasound or CT scans can visualize the kidneys and identify any structural abnormalities or crystal deposits. A kidney biopsy, where a small sample of kidney tissue is examined under a microscope, is often necessary to confirm the diagnosis and assess the extent of crystal deposition and kidney damage. While there aren't distinct classifications in the same way you might see in other diseases, oxalate nephropathy can be categorized based on the underlying cause. We have enteric hyperoxaluria, stemming from intestinal issues that boost oxalate absorption. Primary hyperoxaluria, a genetic condition where the liver overproduces oxalate, and dietary hyperoxaluria resulting from excessive oxalate intake from food. The primary goals of treatment are to reduce oxalate levels and prevent further kidney damage. This involves dietary modifications, such as limiting high oxalate foods. Increasing fluid intake is crucial to dilute urine and reduce crystal formation. Medications like potassium citrate help to bind oxalate in the gut and increase urine pH, reducing crystal formation. In cases of primary hyperoxaluria, specific medications target oxalate production in the liver. Dialysis may be necessary in patients with advanced kidney failure. In severe cases, a kidney transplant and potentially a liver transplant for primary hyperoxaluria may be considered. Preventing oxalate nephropathy primarily focuses on managing risk factors. Maintaining a balanced diet with moderate oxalate intake is important. Staying well hydrated by drinking plenty of fluids, especially water, helps to dilute urine. If you have a history of kidney stones or underlying intestinal disorders, it's essential to work closely with your healthcare provider to monitor oxalate levels and implement appropriate preventive measures. People with inflammatory bowel disease or after bariatric surgery should have their oxalate levels regularly checked. The prognosis for oxalate nephropathy varies depending on the underlying cause, the severity of kidney damage, and the effectiveness of treatment. Early diagnosis and management can slow down the progression of the disease and preserve kidney function. In cases of primary hyperoxaluria, early liver transplantation can significantly improve the prognosis. Recent research focuses on developing new therapies to reduce oxalate production and prevent crystal formation. Novel drug targets are being investigated, and gene therapy is being explored as a potential long-term treatment for primary hyperoxaluria. Further research is crucial to improving outcomes for patients with this challenging condition. Thank you for joining us.